It's about 10 o'clock in London, and I've spent about 12 hours on shift. So I put this together quite hastily because I spent the weekend working as well. But I want to provide you with some insights. Brian says I'm a critical care consultant in London, one of the big tertiary hospitals there. And we've been hit very hard and very fast by this, certainly over the last 3 weeks. So I started off by intubating one of the very early patients we had. Before I think we really knew what we were doing. We learned some lessons from Italy and maybe from China, but we were very much playing catch up as we went along. So I intubated a patient early on, and I don't know if it was that or being in rush hour traffic, but I got the coronavirus pretty early. So I'm back at work and hopefully feeling immune to it, which gives me a certain amount of confidence. But you can see, I work in London South. You can see the data there. We've had 400 admissions to critical care in London South, and we're the hardest hit really in the whole of the UK. So we've had to learn some very fast. Okay, we've had to learn some very fast lessons, and we got a lot of intel from our colleagues in Italy, in the north of Italy. Now, there's a lot of concern really in the UK because we have a sort of very socialized medicine system, as you may know, the NHS. We don't have a lot of critical care beds per head of population. And looking at the pictures from Italy, where they have about 10 per 100,000 patients, we only have about 6.5 beds for the same ratio. So we were concerned really about our escalation, our surge. Here's the data for our patients. I just share this with you because this may be quite typical, really, of US demographics. This was published on Friday for our first 2,200 patients, and you can the column on the right is the patients with the COVID. That's the column on the left. The column on the right is patients with viral pneumonia over the last 2 years. So that's sort of a typical picture of what you'd see admitted to critical care. So you can see the mean age is not that different, and maybe not as old as we would have thought. The mean age is 60, and I'm certainly seeing quite a few 30-year-olds in critical care and quite a few 40-year-olds with no other medical history. You can see it's a predominantly male problem, unlike normal viral pneumonia, 73% male. It's not particularly a problem of pregnant women, like I remember we saw with the swine flu outbreak. And even compared with normal viral pneumonia, there's a low incidence in pregnancy or ICU admission. You can see there's a spread with BMI here at the bottom, which has a greater spread into high BMI, and certainly that tallies clinically with what I'm seeing. And in terms of demographics, which is quite interesting, because I would say that background ethnicity of our country is about 88% white in the UK. But you can see here it's really, it's hitting the Asian and the black community quite hard, which is quite interesting and was something that wasn't really seen in Italy or China, obviously, because of different demographic reasons. You can see, if you look at this column in terms of medical history, it seems to affect people who are reasonably quite fit compared with other kinds of normal viral pneumonia that we see. So if you look at those people who are requiring assistance in daily activities, much lower assistance required in the COVID patients, and not significantly affecting people with severe comorbidities as probably we were led to believe. There's a higher proportion of these patients ventilated very early compared with normal viral pneumonia. And if you look at the age distribution, really from the age of 40 and certainly from 50, that's where the people are being hit. And that's actually quite similar to normal background viral pneumonia, but predominantly affecting males, much more so than the standard viral pneumonias. And it's quite interesting, but it really is the toss of a coin between living and dying. It's almost exactly 50% mortality if you're admitted to intensive care. And this is now 30 days since admission. So we've got 30 days of data since we really started to surge in London. So yeah, it's on the flip of a coin. And you can see our mortality there, yeah, represented in figures 50%. Length of stay, my feeling is it's actually quite longer. And one of the big problems we have, and something we really need to plan for, is the length of time these patients are staying in ICU. So on the ward today, the mean stay was probably around 8 days. And I could see a lot of these patients are going to take a long time to get out, and they're going to have very long weakness, critical care rehab syndromes. And we're delaying tracheostomy, but it's going to be a problem that's going to be a real bulge, and we're admitting new patients all the time. So that's where we're really going to struggle with our capacity. And I think one of the lessons we've learned is we're trying to cohort patients. As they burn out of the hyperinflation acute stage, we're actually trying to cohort them together for those patients who are weaning. But the other thing I've really learned is these patients are really unstable. And just when you think you're getting them somewhere, they fall into a complete heap. They fall to pieces. You've got to restart sort of high-level advanced life support, a lot of drugs, put the ventilation back up. So they're very unpredictable. And that's something everyone's really finding. Just moving through, a lot of advanced respiratory, which means basically ventilation. It's interesting how quick the patients deteriorate. You admit them to ICU, you think maybe you'll get them back to a medical ward, and they almost always deteriorate from being on 8 liters of oxygen on a face mask. They can deteriorate very quickly. So one of the lessons we've learned is if you see someone on 8 liters of oxygen whose respiratory rate is starting to go up, prepare to move them to ICU, because they can deteriorate precipitously in a way that I haven't seen with other medical conditions. We're having a high level of renal support, which is causing a problem for us because we haven't really got enough hemofiltration machines to go around, and this is causing us a big problem. So we're having to kind of rationalize our use in terms of I can talk about this later, but in terms of how we use the machines. Just talking about our organization, what we did at St. George's, we weren't really led from the top in a certain way, because I think as critical care clinicians, we grew it from the ground up, and we went to the top and we said, this is what we need to do. And I think that's because we were very much in touch with our colleagues in Italy. We knew what they were going through, whereas the top of the organization, I think, didn't quite appreciate what was coming for critical care. So we very much grew our solutions from ground up, and we went to the board and said, this is what we think we need to do. And I think it's a better way to grow your response, to get the people on the ground to put the plans into place. We rapidly partitioned the hospital into clean versus dirty areas. We made a whole wing into the COVID wing, and we've gradually escalated our intensive care through that. We've got a clean critical care with a clean operating theatre to try and cohort non-COVID patients, which is really, really difficult, as you may appreciate from the symptoms. We prepared how to rapidly escalate for a large number of admissions, and we would say we'd be hit with 10 ICU admissions in a night. We weren't expecting it. So you really have to prepare for a large unexpected surge. I think early acceptance is important. This is sometimes a struggle with stopping elective surgical activity, which obviously is important to the running of hospitals, but you've got to accept that that's basically going to stop. Everything's going to be very, very disrupted, and everyone's personal lives and work-life balance is going to be completely disrupted, and it's good that you try and get people to accept that early. In terms of our intensive care surge, we went for areas that were easiest to stop first. So we started with our cardiac intensive care. We stopped our operating program. We created our first beds there, and gradually we moved patients out of there to create 21 beds in our first COVID intensive care. We then went into our neuro ICU, where we were able to generate capacity by stopping elective neurosurgery. We've tried to get pan-London organisation and move elective and urgent cardiac and neuro cases into specific standalone cardiac and neuro units without an emergency department, and trying to keep them relatively COVID-free. We've then escalated rapidly into our wards, and these aren't really fit for purpose for ICU, but we'd had a walk around all the wards to work out which were the best areas in terms of organisation. So we went into, say, a neuro day ward, our recovery area, our cardiac wards, and we're requisitioning new wards all the time and working out which is going to be next. We've learned that theatres aren't great as ICU areas. They're too small. They don't have any natural daylight. It's very demoralising for the staff. They're not really fit for purpose for ICU, so recovery areas are better. We've also learned that a lot of the anaesthetic machines are not great ventilators. They can't cope with the ventilation needs of these patients, and they need to be rebooted every morning. You know, the higher the scale of your anaesthetic machine, the better it's likely to be, but the smaller machines really aren't very good. We rapidly did a rota where all our consultants or our senior guys have accepted we're doing 12-hour resident shifts, nights and days, with recovery days, because our younger resident staff have become very quickly stretched. We've done one-day rapid training schools to turn all kinds of non-intensivists into critical care doctors. And we've taken to the simulation center and developed a rapid training program to explain simple ventilation, oxygen, things like that. We've distorted our normal nursing ratios, which are 1-to-1 for our critical care or level 3 patients. And now we're running at a 1-to-4 nursing ratio with healthcare assistant support. Organisation in teams is very important, and we've tried to develop this. So we have our ICU team as the focus. We've got an ICU outreach team who are running around the hospital, screening admissions and working with the medical teams who are referring them and going to the emergency department, because they have the experience really to be able to triage these patients. We've developed retrievals teams for our local smaller hospitals with anaesthesia. We have a COVID intubation team with anaesthesia. They turn up prepped with PPE, with the patient ready to go, because they become very quickly experienced in how to put tubes in and avoid aerosols, and do this very well in terms of prep. And they turn up with all the equipment in bags. So that's working very well. We're trying to organise a proning team. We started with orthopedics because there's a lot of big, strong guys. They're used to turning patients on their side for hip surgery. So that's working quite well using proning and anyone who's not really got a role. We've got lines teams where we've got interventional radiology, vascular surgeons and cardiology who are helping us with intravenous access for hemofiltration, central lines, that kind of thing. That's working quite well, except sometimes they can take a little bit of a long time, so sometimes we do it ourselves. The only problem really with having teams is you go through a high churn of PPE. So if each team turns up with their and gets in their own PPE, there's quite a high churn. So you just got to keep a close eye on the availability in your stock of PPE. Because I guess if you get an intensive care doctor to do the tube, the NG tube and the lines, then you use much less PPE. So that's one disadvantage of working in teams. We're trying to minimize the noise of communication and keeping we're using WhatsApp, 2 dedicated channels of that, where no one's allowed to post freely, only designated posters can go in. And we have a SharePoint where all our information is housed. And this is the other hazard of having orthopedic surgeons potentially doing airway maneuvers. This is how an orthopedic surgeon secures the airway. So just a little bit of light humor there. I've just got a bit of information. I know I'm probably running over time here. I don't want to run on too long. I just had a bit of specific intelligence about what we found out. And I think we were ventilating people probably a bit too hard initially, and we've really backed off that. We've been running lower PEEP and probably better tidal volumes. Because a lot of these patients, when they first come in, they're not like acute lung injury ARDS patients. If you look at the left side of the screen, they're much more like these patients with actually very good compliance. And actually, if you run these patients on very high PEEP, low tidal volumes, they don't do so well, we think. So we're running them on lower PEEP, using higher inspired oxygen concentrations, and then escalating from there. And I think that's one of the things we've learned, rather than trying to run everyone on high PEEP, because that does cause a bit of hemodynamic instability and potentially has a knock-on in terms of kidney function. We're sedating patients quite significantly and trying to take over their ventilation rather than using spontaneous ventilation. We are using everything at our disposal, but we're starting to hear sounds that we're running a bit short of some of our sedative agents, like propofol. I heard we've got about 3 days left in the UK of propofol supply. So we're actually moving to benzodiazepines to try and reduce our propofol. So it's something very much worth keeping an eye on, and working closely with pharmacy just to make sure you're not running short of stock, because you need to think in advance about what you can substitute. And we're using quite a lot of paralysis. I kind of skipped the fluid balance, but the lesson we learned was very much that these patients have often been at home with very high temperatures for 7 to 10 days. A lot of them are very dehydrated. So rather than going for a negative balance and trying to dry them out, which we did initially, we've actually been giving them a reasonable amount of fluid, and we've not been trying to run significant negative fluid balances, because we thought that possibly exacerbated some of the renal failure we were seeing. And we're certainly seeing quite a high level of renal failure, particularly in our patients who've got a sort of hypertension background, and really they're not recovering from this. So there's potentially a big downside risk of patients requiring longer term dialysis and longer ICU stays. Another thing we learned is that APTT is not very useful, and we switched to activated clotting time, which is something we brought in from cardiac theatres, because a lot of patients, they clot off their filters. So getting anticoagulation right is quite difficult. It's important to have a good scheme for tracheal intubation. This is what our anaesthetists have produced. And if anyone wants to share this, I'd be very happy to share when I'll sign up to Slack later on. And I'd be very happy to share any of this stuff with anyone. This is our PPE. This is local guidance, which comes from our national guidance. Now, there was a lot of focus on PPE initially, and I myself talked to the newspapers because I was very concerned about the problems with PPE. We seem to have better PPE stocks now, certainly around critical care. And you can see all our, in a critical care area now, everyone's wearing FFP3 masks and full PPE, including visors, in all of the intensive care areas. And so far, this is available. As I mentioned before, you just have to be maybe a bit economical with constant doffing and donning. And when people go into ICU, they have to stay there for a significant period of time and can't come out for short breaks all the time. And again, the team approach can churn through your PPE quite quickly. So something to watch. For COVID positive wards, we're not using FFP3 masks. We're using surgical masks with the rest of the protection, but maybe not a full gown. And then green is non-COVID wards, which we're using a similar thing. And then blue is no PPE required. Anything that's happening in theatres where there's a risk of aerosol, it's full PPE. Because even in asymptomatic patients, that's a significant risk. And we're certainly seeing quite a few nurses from endoscopy areas, from ENT areas, who've probably got aerosols in asymptomatic patients early on. This is something we did that was very simple. We laminated a sheet for daily targets. So rather than putting into our computerized information system, we put this by the side of the bed, and we get a wipeable pen, and we circle the things for easy communication to the nursing staff, who may not be critical care nurses. They may have stepped up, they may not have much experience in critical care. So this, we found very simple aids are quite helpful for them. So I think my overriding message is plan for the very, very worst and just keep your fingers crossed, hoping for something better.
Dr. Fletcher, this is phenomenal. This is exactly the type of insights and practical frameworks that I know this group is looking for. So thanks for putting such thought and time into this. Just extraordinary.